Okay, now we're at the point where I am going to offer you some questions, and hopefully you retain the information you learned previously in this lecture. So I'm going to ask you 10 questions, and we'll do one by one, and hopefully we get a good answer from you, and I'll be looking for answers on the Q&A on this. So let me know how you do. Question number 1. It's about peak flow rates. Typically, muscle weakness in neuromuscular disease patient does not demonstrate significant changes in peak flow measurements. So what I'm asking you, if you have a neuromuscular disease, typically it really doesn't demonstrate any kind of significant changes in peak flow measurements. Is it true or false? Please type in the Q&A what your answer is. And the answer is false. Peak flows are used all the time with this type of disorder, and also they are the easiest things to measure, so definitely 100% sure peak flow tests are offered. Question number 2. It pertains to maximal expiratory pressure, MEP. MEP is a straightforward test in which individuals are asked to perform expiration after a full inspiration to total lung capacity with an open glottis against an open mouthpiece. MEP reflects the strength of abdominal muscles and other expiratory muscles. So is it true or false? MEP is a straightforward test in which individuals are asked to perform expiration after a full inspiration to total lung capacity with an open glottis against an open mouthpiece. Is it true or false? Q&A, guys. And the answer is false. It's actually a closed mouthpiece. Question number 3. Which one is correct? It is the most common acquired disorder of neuromuscular transmission. It's a production of pathogenic autoantibodies that bind to components of the acetylcholinesterase receptor. The incidence is estimated at 0.3 to 2.8 per 100,000 worldwide, with a prevalence about 700,000 people globally. In 1934, cholinesterase inhibition was demonstrated as the first effective treatment. So, with this information, which one is it? Is it A, ALS, B, muscular atrophy, C, myasthenia gravis, or D, Guillain-Barré? Which one fits the ticket? Q&A, guys. And the answer is C. This is myasthenia gravis. Question number 4. Maximal inspiratory pressure, MIP, and maximal expiratory pressure, MEP, are direct measures of respiratory muscle strength and may be more sensitive in detecting late stages of respiratory muscle dysfunction as compared to spirometry. True or false? Does MIP and MEP better than spirometry with detecting late stages of respiratory muscle dysfunction? True or false? Q&A, guys. And the answer is false. It's actually better at detecting early stages. I try to trick you. So it's good for detecting early stages of respiratory muscle dysfunction as compared to spirometry. Question number 5. This disorder refers to a group of genetic disorders that are characterized by degeneration of the interior horn cells, resulting in muscular weakness in over 95% of the cases. It is an autosomal mode recessive disorder as a result of genetic mutation. So which one is this? Is it myasthenia gravis, spinal muscular atrophy, Guillain-Barré syndrome, or ALS? Q&A, guys. The answer is it's a spinal muscular atrophy. And There are many different types of spinal muscular atrophy. There's type 0, there's type 1, and typically these babies died very young at one point, but now they have an extended life cycle as a result of new interventions, new medications, and also the use of non-invasive ventilation for them. Question number 6. In neuromuscular weakness, the total lung capacity is typically low, the FRC is normal, and the RV is high. True or false? What do you think? Put it in the Q&A, and the answer is true. So I'll ask you, why is the RV high? Remember I was telling you earlier that patients with neuromuscular disease cannot expel all the gas from their lungs, so they end up getting air trapping. Air trapping leads to elevations in RV. Question number 7. It occurs due to the production of pathogenic autoantibodies that bind to components of the neuromuscular junction. The most common being acetylcholinesterase receptor. So, which one of these disorders fits the ticket? Is it Guillain-Barré syndrome? Is it ALS? Or is it myasthenia gravis? You tell me. Remember the Q&A. Which one is it? A, B, or C? And the answer is C. We mentioned this question earlier. I was just testing you again to see if you got it. Question number 8. The FRC and the RV may be normal or low in chest wall deformities. So if you have a patient who has a chest wall deformity, will the FRC and RV be normal or low, or will it be elevated? Is it true or false? And the answer is, make sure you put it in the Q&A, is true. Sometimes patients with chest wall deformities have lower values of FRC and RV, or they could be normal, but they're certainly not going to be higher. Question number 9. Peak cough flow values lower than 160 liters per minute have been shown to be a good predictor of an ineffective cough and indicate those at risk of developing acute respiratory complications with neuromuscular disease. It's a true or false question. Make sure you put your answer in the Q&A. So again, peak cough flow values lower than 160 liters per minute have been shown to be a good predictor of an ineffective cough and indicate those at risk of developing acute respiratory complications with neuromuscular disease. And the answer is true. Yes. Patients with a peak cough flow less than 160 are at risk, and maybe you have to do some abdominal thrust with them. You have to do some stacking with them. You have to improve their cough mechanism. Here's question 10, which is the last one on pulmonary function testing. Maximal inspiratory pressure, MIP, and maximal expiratory pressure, MEP, are direct measures of respiratory muscle strength and may be less sensitive in detecting early respiratory muscle dysfunction as compared with spirometry. So this is a true or false. Read the question carefully and tell me what your answer is. And once you have your answer, put it in the Q&A. So I'm saying maximal inspiratory pressure, MIP, and maximal expiratory pressure, MEP, are a direct measure of respiratory muscle strength and may be less sensitive in detecting early respiratory muscle dysfunction as compared with spirometry. And the answer is false. It's actually more sensitive. We actually asked this question before, but in a different way. So the answer is false. It is actually more sensitive rather than less sensitive. You guys did great. So at this point, we're going to move on to our next set of questions, and I hope you enjoyed these questions. If you have any questions for neuromuscular and chest wall disorders, this is a good time to put it in the Q&A, and I'll be more than happy to answer it. So we're on a brand new topic now, and we're going to be talking about lung function assessment by iOS. Question number 1. Sound waves are superimposed on the normal tidal breathing, and the disturbances in flow and pressure caused by the external waves are used to calculate parameters describing the resistance to airflow and allow measurements of lung mechanics and require minimal patient cooperation. So what am I talking about? Am I talking about A, B, C, or D? Remember to put your answer in the Q&A. So go 1B, 1C, 1A, whatever you like, your choice. So that's the first question. And the correct answer, of course, is B. This was a given. So, obviously I explained it to a T what it is. Question number 2. One of the major disadvantages of this test is that it does not measure resistance and reactance at different frequencies, and it's difficult to interpret. True or false? Is this one of the major disadvantages of this test? Put it in your Q&A, and the answer is false. Actually, this is one of the major advantages of this test, because it does measure resistance and reactance at different frequencies. Question number 3. The frequencies of waves delivered in iOS range from 15 to 40 Hertz, and frequencies greater than 40 cause discomfort. Is it true or false? Put it in your Q&A, and the answer is false. Typical ranges of iOS go from 5 to 30, where typically anything greater than 30 causes discomfort. You would not want to go up to 40. Question number 4. It is the sum of all forces which oppose the generated impulse, and it is measured at a frequency and is the ratio of the difference in pressure and changes in flow at that frequency. What am I talking about? It is the sum of all forces which oppose the generated impulse, and it is measured at a frequency, and it is the ratio of the difference in pressure and changes in flow at that frequency. So exactly what am I talking about? Again, question number 4, Q&A. What's the answer? Is it A, B, C, or D? And the answer is it's A. It's impedance. That is the definition of impedance, which is a very important part of this test. Question number 5. It includes 2 components: the inertia of air column to move and the capacitance of the lung, and the capacitance can be interpreted as a property which reflects elasticity of the lung. The capacitance component of the reactance is defined to be negative in sign, where the inertiance is defined to be as positive. So what am I talking about? Which one of these, resistance, resonant frequency, reactance, coherence, which one am I talking about? Question number 5, put in your Q&A. And the answer is reactance. This is exactly the exact definition of reactance. This is how you could read the charts of exactly how the patient responds to any kind of bronchodilator or any kind of small airway problems. You're going to see this a little later in the PowerPoint that I give. Question number 6. It is defined as the frequency at which inertial properties of the airway and the capacitance of the lung periphery are equal. In other words, the frequency at which the total reactance is 0. What are we talking about? Are we talking about resistance, resonant frequency, reactance, or coherence? Q&A, guys, number 6, Q&A. And the answer is resonant frequency. It's pretty right there in the question, too, so you can't go wrong with that one. Question number 7. It is another important parameter and is used to determine the validity and quality of the test results. It reflects the reproducibility of impedance measurements. So basically, it is a parameter that is used to determine the validity and quality of the test results. Is it resistance? Is it resonant frequency? Is it reactance? Or is it coherence? And the answer is, make sure you got in the Q&A, it's coherence. Coherence is the tool used to determine whether the test is valid. Question number 8. The clinical application of IOS technique can be used on all of the following except response to bronchodilators, bronchoprovocation testing, asthma and COPD, cancer, or interstitial lung disease. Which one is it? Remember Q&A. The clinical application of this technique can be used on all of the following except. And the answer is D, cancer. It's not normally done with patients who have cancer, lung cancer, or any other type of cancer, so it's not a valid test for cancer. But everything else is perfect. Question number 9. A study published by Nagy concluded that using IOS as an alternative method for measuring resistance and obstruction may be useful when patients cannot perform body plethysmography or spirometry exercise testing. So which one is it? Is it asthma and COPD? Or is it bronchoprovocation testing? Is it ILD? Or is it cystic fibrosis? So if you listen to the PowerPoint presentation I gave, it shows that bronchoprovocation testing was used in Nagy's study. Final question, number 10. A very recent study conducted by Reham studied the correlation between IOS and spirometry on patients diagnosed with rheumatoid arthritis-associated ILD and concluded that IOS can be used as an early screening technique to identify proximal and distal pulmonary tissue affection even before spirometry changes appear. What conditions benefit from this study? Do it on the Q&A. So based on this question, which one is the best answer? This is a freebie, guys. Of course, it's ILD. ILD. That's the correct answer. All right, everybody. Listen, if you have any questions in regard to lung function by IOS, please put it in the Q&A, and I'll be more than happy to answer any kind of questions you have on that. And if not, I want to thank you for joining our webinar, and you guys have been great, and I hope you spread the word amongst your friends. Thank you.